If you're calling in with the last two, that's me. If you're calling in with the last two digits on your phone number 14, can you identify yourself? Yes.
I think that people are a bit confused. There isn't a lot of sound on here right now, and some people are thinking they don't have sound. I think Linda Kay was having a bit of a problem with that, and I just see something from Diana, so maybe we could test the sound for them.
Can everybody hear the boardroom? We're throwing tags at the boardroom's talking.
I can hear the boardroom's fine.
Yes, I can now.
Okay, we're just doing a roll call of directors. It takes a bit with the numbers, and we'll get started shortly.
Who is the bars? Is that someone? I don't see.
Billy, get out of there.
Good evening, everyone. We're going to get this meeting, first meeting of the year for the West Kootenay-Boundary Regional Hospital District going. My name is Stuart Horn. I'm the Secretary Treasurer of the board, and I have the honor of starting off the first meeting of the year with the election of chair. With that, I'm going to call for nominations from the floor for chair 3 times, and I'll go for the first time. Director Jackman.
I'll nominate Director Hewitt.
Director Hewitt, do you accept?
I do.
Thank you. Calling for nominations a second time, Director Martin.
I'd like to nominate Director Marino.
Director Marino, do you accept?
I do. Thank you.
Thank you. I'll call for a second time for nominations. And a third and final time. Okay, with that, we will move to candidate speeches. So each candidate gets 2 minutes to address the board, and we'll start with Director Hewitt.
Thank you and good evening, everyone. Thank you for the nomination, Director Jackman. I think with my 3 years of previous experience as chair of this board and my 9 years as mayor of the village of Castle, I have the skills that it takes to chair this committee. And having been a resident of this area for a lot of years, all my years almost, I have visited every one of the communities that is represented by this board, either as been here as a resident or visited as a baseball or hockey mom. So I really understand the area that is served. And I also understand the challenges faced by rural and remote communities. And living where I do, I really understand that. Having grown up in Nicusp and been at and visited their hospital, and I was really proud of the support that this board gave for their improvements to their ER. And I know the challenges faced by the area north of Caslo and their issues that they have with receiving quality care. So I think I've got a well-rounded background to serve in this capacity. And I do also appreciate the existence of our larger facilities. I'm glad that we have been able to support the improvements at KBRH. They're vital to supporting our residents. And so thank you for your listening and hope for your support.
Great, thank you. Director Marino.
Hello, everyone. Thank you for the nomination, Director Martin. If the board members will have me, I will gratefully serve them as their chair. This first year was a learning experience for me for sure, and I really can't believe it's been a year already. I believe that my background in healthcare as an administrator and in human resources serves me well in terms of understanding the process and some of the items and issues that are brought forward to this committee. For example, when I was administrator in Trail, I actually oversaw or was the administrator for the Kootenay Renal service. So the nurse manager for the service reported to me, and luckily she knew what she was doing. In terms of understanding what the needs are for healthcare in the whole area, I was on the senior management team for the West Kootenays. So I, as a HR director, visited all the sites in the West Kootenays and the Boundary. So I do have a knowledge of what they look like, what are some of the issues, etc. And in terms of serving as chair, I have to say we just had a in-service today for Robert's Rules of Order with the Regional District of Kootenay-Boundary. I know I need to up my game on that end of things, and I will work hard at doing that so these meetings run more smoothly. That's all I'd like to say. Thank you very much for your consideration.
Great, thank you. We do have a little bit of a split. We've got 4 directors in the room here and the rest online. I think I'd like to keep the election process streamlined. If everybody could use email. There's 2 email addresses in the chat function. If you could open that up. There's my email address and Angela's email address, who's helping us out today as recording secretary for the meeting. Christine's away on vacation for her 50th birthday. So Angela's helping us out tonight, but if you could email your vote to both of those addresses, we will tally them up and get back to you. Thank you.
I don't see the addresses in the chat box. I
If you
think I
scroll to
found
the
them.
top, they'll be
Thank
up
you.
there. I'll put them in again.
Nope, they're there.
get to use our ballot box here. Where's mine?
Okay, you're on. Now see here, when you see the dot here, you'll know that people are chatting in the meeting messages panel. Open.
Hi, Sean. Welcome, Director Zelznick. If you could just check chat, there's 2 email addresses in there. We are currently doing the vote for chair. Director Marino and Director Hewitt are standing for chair. If you can send your vote to those 2 email addresses that are in chat. Thank you.
Which email? God, I turned it now.
Director Zelznick, can you also mute as well? Thank you. Okay, we're gonna call about 30 seconds to get your vote in if you haven't voted yet. We are missing a few.
It's Bill Wendman here from Fruitvale. Can I confirm that you received mine because I had to use a different email account because I couldn't use my village one?
Yes, Director Redmond, we did.
Okay, thank you.
As did I as well. This is Grace. I couldn't send it from my RDKB one either.
Yeah, it came through Director McGregor.
This is Judy Wilsey. Can I confirm that my vote came through?
So Director Wilsey, I do not have your vote.
Well, I sent it to both email addresses, so I'm a little confused. Do you have a suggestion for me?
Did you get the .bc.ca? Because a couple of people are putting them through .com.
I have it.
You have hers? Okay. We do have yours. I just didn't get it.
Okay. Thank you.
Okay.
Always check your sent file, then you'll see if it went.
You on here, Stuart?
Yes, Director Zelzak, we got yours. Thank you.
Yeah. Thank you.
Okay, I'm going to call the vote and we're going to go into the other room and just tally the votes.
Hi, Linda Kay. Can you hear me?
She signed out and went to get her tablet because she couldn't get her sound to work.
She just texted me that she could hear me,
Can't
so
hear
that's
you.
great.
Okay, everyone, thanks for your patience. Your chair for the 2024 year is Director Hewitt. And before I pass the chair over to our chair, I will do the election of acting chair. So for acting chair, I'm going to call for nominations 3 times, and I'll call for the first time nominations for acting chair or vice chair for the year.
Nominate Director Marino.
Director Marino, do you accept?
I will.
Great, thank you. Nominations for a second time for acting chair. And for a third and final time. Vote by acclamation, your chair, our vice chair for the year is Director Marino. So with that, I'll look for a motion to destroy the ballots for the election of chair. Director Weatherhead, Director Jackson, thank you. Any opposed? Great, thank you. And I will pass the chair over to Director Hewitt.
Thank you very much, Stuart. Thank you for your support for my position as chair. And I want to thank Director Marino for serving as chair for the last year. It was a pleasure working with you as your acting chair. And I think it went well, and we get to continue to work together, which I think is going to be great. Thank you. And if you'd like to give an address now, Acting Chair Marino?
Yes, thank you for that. Chair Hewitt, yeah, thank you very much for accepting me as acting chair. And I found working with Director Hewitt or acting chair Hewitt very amenable, and I think we did well together, and I think we'll continue to do that. Thank you.
All right, so we'll move on to business. The first order of business is the appointment of directors. So the following regional directors, alternate directors be appointed as directors to the West Kootenay-Boundary Regional Hospital District for 2024. I won't read them all, but are there any changes that you should be taking back to your boards?
Okay, there is one change that staff had. The director for the Village of Midway should actually be flipped.
Okay.
Director Dunstan is the alternate, and Director Wilsey is the main director. And Chair, these can also be looked as a block.
Yes.
5952.
All right. And the only one is Director Zelznick. Are you going to be the representative on this board, or will it be Councillor McLaren-Coe?
It'll be me. I'm through the chair. To the chair.
Okay. All right. So at this point, we've got it listed opposite. So do we need a motion from your council, or can we just make that switch now?
Actually, council did do it, but I guess you haven't got the update.
Okay.
Sorry, yeah, through the chair, you could do it now, and then as long as they ratify it before next meeting, it's fine. Director Zelznick could be sitting as alternate for today's meeting, for example, if that was the case.
Okay. All right, so we'll move those as a block with those two changes that the Village of Nakusp representative is going to be Tom Zelsnick, and the Midway will be Judy Wilsey. So can I have a motion to move those two sets as a block? So Director Weatherhead and Director Page, any discussion? Anyone opposed? Motion carries.
Chair, was one logistical item. I believe the delegation from BC Renal was going to attend at 6:30. I believe they're calling in from Australia, is what Landon had emailed. So I think, depending on when they come on, you might need to pause the meeting and go to that delegation.
Okay. So we'll get, so you'll let me know when
I'm
they going on?
Yeah, it's Dear 11. I am on. I don't know. I think some other people also from BC Renal are coming who are in Vancouver, but yes, I'm on.
Okay. Excellent. So did you want to wait for the other individuals to log on?
I'm also here, Adira. Sarah
Great.
Thomas
Yes,
from
so
BC
Sarah
Renal
also
is
is.
here. Yeah.
All right. Great. So do we have to make a motion to reorder the agenda, or can I just
Change the order of the agenda to accommodate the delegation.
All right. So can we have that motion then?
Sure.
Moved by Director Jackman. So moved by Director Jackman to move to item 7.1 at this time. Do we have a second? Chair Weatherhead. All those, anyone opposed? That motion is carried. So welcome to our delegation, and thank you for representatives from BC Renal for attending. I understand you have a presentation that you will be giving. Do you have something that you've emailed to Angela, or will it be a verbal presentation?
So it's Donna Jan. Yeah, thank you, Dr. Levin. So it's Donna Jansen's Renal Program Director speaking from Interior Health. And so when I had the benefit and pleasure of speaking to this committee and meeting last meeting, there were questions about the possibility or lots of questions about asking about dialysis services in Nelson. And when I had talked with this group last meeting, we had talked about the possibility of people coming to speak with everyone from BC Renal, because BC Renal and Interior Health work collaboratively together when we talk about planning or any need for dialysis services in the province. BC Renal works with all of the renal health authority programs in talking about the need for services and any future developments of such services. So Dr. Adira Levin is here, and Sarah Thomas are here from BC Renal to partner with myself. And our medical director, Dr. Marie Michaud, is on call, and she just has messaged me she's going to join imminently. But perhaps I'll turn it over to Dr. Levin and Sarah to introduce themselves, and then we don't have a formal presentation. We thought that we would like to have a question discussion time to share a little bit of how BC Renal partners with health authorities in planning for dialysis services in the province. So Dr. Levin, if I could turn it to you to introduce yourself.
Sure. So my name's Adira Levin, and I'm a practicing nephrologist, kidney doctor, but also have the privilege of being in charge of planning services around the province with the support of all the different health authorities and input from them. And so, Sarah, over to you.
Hi, everyone. My name is Sarah Thomas. I am from BC Renal. I am the chair of our Facilities, Equipment, and Planning Committee, and we work with all the health authorities to look at our facilities, projections, as well as the equipment, the expensive dialysis equipment that we need to dialyze our patients. So we work alongside with Donna and the other health authorities to provide that support. So thank you for having us.
Well, thank you for attending. So we'd just like us to open it up to the floor at this point?
I think that would be great. I know the last meeting there were some general questions in regards to what goes into planning dialysis services in communities. I know there's been incredible advocacy from Nelson and community, lots of concerns around the burden that is placed on patients when they need to travel from Nelson and area to our in-center unit in Trail, and considerations when we go into planning mode for a new dialysis unit.
All right, thank you. So for those online, if you could please put your name in chat, that would probably be the easiest way for me to keep track of who has questions, because it'll be hard to see hands. Does anyone have questions?
Diana.
I'm sorry, but members of the public aren't allowed to ask questions except during question period. All right, any members of the board have questions for our delegation? Director Page.
Director Watson and Shannon.
And Director Watson. Next. So go ahead, Director Page.
Yeah, so we're seeing a lot of advocacy in the area for renal service in Nelson, and I'm new to this service for the most part. I'm trying to understand what some of the barriers might be from your guys' perspective at bringing those kinds of services into the hospital here.
Right. So maybe I'll start and give sort of like the high level perspective. So I think we're all very sensitive to the hardship that dialysis brings to all patients, no matter where they are in the province. And in a perfect world, there would be services everywhere for everyone, but we don't live in a perfect world. The complexity of delivering dialysis services requires not just equipment, but trained personnel, sustained skill sets of trained personnel. And there are many, many sensitivities around, and there's many things that go into the building of a dialysis unit. And the person power required, that is the trained nurses, etc., are few and far between and need a core group to be maintained. We also have had experiences in other communities where the notion of the commencing of a nurse staffed dialysis unit actually steals nurses from your emergency room department and your hospital, because it's a nicer shift, if you want to put it that way. And so you actually steal from Peter to pay Paul. And so the things that go into where should a dialysis unit go in the present time is not just, do you have a space and can we get machines, but rather the whole area. What are we going to lose and gain, and what are the other alternatives to ensuring that people get access to best care? And so there is, as many might know, the increased emphasis on something called home-based therapies, where people who are well enough can actually do dialysis at home. There are units where there are no nurses available, where it's truly a self-care unit. And then there's the notion of travel. And at the moment, that is the current best option is the travel option, but we also recognize that that has its own challenges, as it does in other places around the province and the country for that matter. So it's a long-winded way of saying, like, it's not as simple as, oh, let's just build another dialysis unit. There are so many things that go into it, and what we do with the interest of the whole province, as well as interior and taking interior health's needs into consideration, is what is the current best places, what are the current best places to build and sustain treatments that are the least destabilizing and the safest for staff and patients and the communities. And so that's how we make decisions. when the world aligns differently, and if there was a plethora of nurses and a burgeoning population, then we actually keep our eye on that ball on a very regular basis, and that's what Sarah's group does. And every year to 6 months, we reevaluate what are the needs, were the decisions right, can we change it? So it's not that because we're having this conversation and saying not at this time, it doesn't mean that it will never be. It's that at this time, there is no ability to support a unit. I hope that's a reasonable place to start, because it is a complicated issue, right? We don't all have open heart surgery wherever we want it because of the same kinds of considerations. So happy to answer any more.
Did you have a supplemental, Director Page? No. Thank you. So I have Director Watson, Director Marino, Director Davidoff, and Director Jackman.
Thank you. And apologies, the conversation we had was quite a few months ago, and remembering all the details and what questions we had, should have wrote them down and kept them handy. But the premise is essentially what Director Page referenced, is that we have a very sincere and pretty motivated, there's a need, there's a really, really big need. And you mentioned open heart surgery, and it's unfortunate to have that comparison, because you go to the hospital for open heart surgery, hopefully once. You don't go 3 times a week, where you're traveling and you're ill, and you are being further ill by the fact that you can't access the service in a reasonable manner. We do have residents that are 3 hours just from Nelson, let alone Trail. And so I want to know, what will it take? Okay, it's not just the space, it's not just the equipment, is it staffing? Because the need is there, it's evident. And the ability to provide healthcare also includes the access to those services. The more we centralize, the more we're increasing the risk to those patients. And so I would like to know what it will take and what those complex issues are. And if it's funding, well, that's what you guys ask us for every year.
So it's not funding. So it's not funding. The funding is absolutely there. It is personnel, trained personnel, and sustaining that specialized nursing group at the expense of not having emergency room nurses and ward nurses in Nelson. Like, that's what will be for. And I think the other thing is, we are suggesting and hoping to develop a proper kidney care clinic in Nelson, because the important thing, which I think is very exciting and needs to be put into the equation, is for the current 9 people that are in and around the Nelson area, which can change to be 4 or increase to be 11. And that's one of the other things that's difficult, to maintain a trained workforce for a fluctuating need. But what we are looking at doing is establishing a kidney care clinic, which will do a few things. One is, we have now new treatment strategies to delay the progression of kidney disease, so you don't need dialysis, and that serves, hundreds of people, not 9. And that actually increases people's awareness, prevention of kidney disease and its complications. And that's what we're advocating for in a number of communities, to really enhance the care that's delivered locally. And then, if the numbers grew in Nelson and the nursing workforce grew in Nelson, then there would be absolutely the ability to deliver the care. But right now, what you can't do is say that we're going to have dialysis in Nelson, and then you don't have any nurses, and then you have like chaos on every given day that you don't have a nursing supply, or someone is sick. Then you've actually created a different kind of emergency need. And so we're also looking at, but don't have an answer yet, to more creative ways of transporting people, so that would be less onerous on the individuals. So those are things that we're looking at. So no, as I tried to articulate before, we're not taking our eye off this ball, and we're not ignoring Nelson. We're just trying to come up with, in the current moment, what are the safe strategies. So one is prevention and early intervention, and even later intervention to delay progression. The other is building safer and more reliable ways to do transportation. And then the third one is, and if the need arises, then there would be dialysis services. So I think it's a not forever, it's a not now, and we'll continue to work with Interior Health to develop these solutions.
Thank you. Did you have a supplemental, Director Watson?
You can go ahead with your speakers list.
Sorry, this is Dr. Marie Michaud. May I make a comment here?
Yes, you may.
Hi, so I think I missed the introductions. I'm also on call today in Kelowna. I'm one of the nephrologists working out of Kelowna, and I'm also the medical director of Renal for IH. Thank you for inviting me to the meeting. I just wanted to say, so what Dr. Levin was talking about in terms of the kidney care clinic, I wanted to veer a little bit back to the 9 patients that currently need dialysis right now. And I wanted to talk about a little bit more about home strategies for dialysis, which I'm not sure how much you know about our home strategies, because in BC, we supply all the equipment people need to dialyze at home. We supply all the training they need to dialyze at home, and we supervise them carefully to support them with their home dialysis. And we have different kinds of home dialysis available. Some people are afraid of dialyzing at home, but we do provide them an awful lot of support. And I was wondering, Nelson is such a, I guess, what would I call it? Hands-on supportive community for people. One of the things that we could do too is when we train people to do their home dialysis, we also will train family members or support people to help them with their home dialysis, or to dialyze them on the days that they're not feeling well and they need increased support. So if Nelson had volunteers that wanted to participate in a program to support their dialysis patients, and we worked at training them to do their dialysis at home, like I wonder if we could work on something like that now while we're not able to provide them with a dialysis unit. We dialyze patients at home too that are quite sick, but because home dialysis is more gentle on the heart than dialysis in center in places like Trail, because we can do it over longer periods of time, we can do it more often, we can take the fluid off slower. People with heart disease are sometimes do way better on home dialysis. So that is something that we support people to do all across BC, right up into Yellowknife and like far people that are far from facilities. We support them to do their own dialysis at home. And so that is something that I think we should really promote with this patient population.
You know, I think that's right, Marie. Thank you for highlighting it. I mentioned it only in passing, but I think that's a really good thing to remember. And I think you're right to highlight the huge community sense that exists in Nelson, and perhaps this would be a really excellent way to promote that community of care, so to speak, and still promoting independence. And there is a lot of information that says that people that dialyze at home, no matter how frail they are, actually do better, as you're saying, than people who actually go to a facility. And that's one of the reasons that we try and get most people in the province as much as we can to be at home. So those are really good points. Sorry, I'll stop now.
Okay. Well, thank you for that. So we'll go back to our speakers list. Director Renal.
Yes, thank you, Chair. I originally had a question about the statistics of how many people in the Nelson area need dialysis, and you said there's 9. But last time we spoke, there was also mentioned that you might have 9 patients, but some of them have to go to Trill because of the specialty service provided there. So, you know, I don't know what those stats are, and do the stats there, the statistics there now, support having a renal unit in Nelson?
So when we talk about a patient population, I can maybe start this one. When we talk about a patient population, we don't get down into the details, especially when we have such a low number as 9, because then we'd be potentially identifying somebody's specific treatment plan. But in that group of 9, there potentially are people that would still need to continue to travel to trail because they may have a more complex treatment plan. And I would look to Dr. Levin or Dr. Michaud to give a little bit more generalities around complex treatment plans that require people to travel to an in-center unit or a facility dialysis center, no matter where they lived, because of their treatment plans. But I think more generally, what I think you may be getting at is there a specific or magic number of patients that are required to build a dialysis unit? And maybe what I'll do is I'll first ask Sarah to answer a little bit about that, and then see if Dr. Levin or Dr. Michaud want to talk about complex treatment plans.
Thanks, Donna. There really is not a magic number, but it has to be a sustainable a number that doesn't, that we can say that we can sustain a certain amount over time. Because as Donna alluded to, a lot of patients do get sick. They may have to go back into hospital. And if we open a dialysis unit in a rural or a smaller community, and now 3 patients need to go back to the hospital, now we've opened a dialysis unit for 4 patients or 5 patients. And the amount of resources that would go into that is it's a bit more than dialyzing 5 patients. So there is not a magic number at this point, but as we said, we are looking at it. I think having a KCC, which means a kidney care clinic in the Nelson area where we can prevent people from going on dialysis with the new medications, or we can, extend the progression of dialysis, is a much better option. It will also look at the larger community and the surrounding community and offer that care and that nephrologist support as well as a full multidisciplinary support. So at the moment, we are weighing out the amount of patients, but also looking at the whole ecosystem of our nursing staff. This is a specialized nursing, much like an ICU nurse. You can't just put a regular nurse into a unit like this. They require training, which the training is about 4 months. They also, if they're that far away from a hub, which is in Trail, it's a little bit more tricky for the nurses to troubleshoot if something does go sideways. So there's so many factors, but really just sustaining that consistent number over time is what we really take into account.
Do you want me to tackle the complexity of patients question?
Yes, go ahead.
I think really I'd have to look through the files of the patients that are currently dialyzing to see, first of all, whether they had to be in Trail to dialyze, whether they were safe to dialyze in a community unit, which is what you're hoping to get for Nelson, or whether they're safe to dialyze at home. So we really actually, without knowing the histories of the individual patients, we can't tell you whether they're too complex to dialyze in Nelson.
Somebody's unmuted with it. So does that answer your question, Director Marino?
Yes, thanks.
Thank you. All right, so I have Director David off next.
Yeah, thank you, Chair. I was unmuted, just getting ready for the question. So congratulations on your election as Chair. My question also was about statistics and understanding the number of patients in our hospital board area, understanding where the current hubs are, and it was very informative. I was not aware of the home how much home dialysis is possible. So maybe instead of asking and taking up time here, is it possible for one of you to email us to the board some statistics about number of patients within our hospital district that require dialysis, how many are in home dialysis, and then where the hubs are, because I'm not sure. I know there's one in Trail, but where else in our hospital district? Is there one in Creston? Or Creston's not ours, but is there one in Grand Forks, or like where are they? And so instead of taking up a lot of board time here, is it possible for you to do that? And then if you could also add in the report back to us, what does it take to set up a kidney care clinic? Because that sounds like something that is a possibility that could be put in place, before a hub would ever be considered. So maybe, hopefully someone's taking notes on this, but, this is kind of, I think, would help us as a hospital board understand the need, understand the possibilities for providing care, and really appreciate all of you being on this call, because I think each of you has added, some really important information for us to understand the extent of the need, and then the possible options. So I found this very helpful. So is that, I don't know who I direct this question to. Who would take this on?
Donna,
yeah. Sorry.
I was just going to say, I think that your points are very well taken. And I think that information is exactly the information that we use throughout the province, but in Interior Health as well. And we can certainly, and I think to underscore what Dr. Michaud and Sarah said, all of the services are funded by BC Renal. So there is, what is really wonderful about what we've set up in the province is that it's not the funding that's the issue, right? It really is the human resources and the sustainability of that in the context of the number of patients and their needs. And so, again, to reiterate, it's difficult without having the specifics of the 9 patients who could become 4 patients if people got transplanted. Like, there's lots of different journeys that people with kidney disease have, and perhaps even, showing the board, if they're interested, all those possibilities of the journey of what happens. And the kidney care resources would be fully funded and would be something that I know that Dr. Michaud and her colleagues in Trail are looking at establishing. That wouldn't require anything other than some space. So I think that would be something good. But I'll turn it over to you, Donna, to add in.
Thank you, Dr. Levin. Yeah, I think it's a great request, and something that we're more than happy to support. Lannon and myself met with the mayor of Nelson last week and had this very conversation, and have made some commitments along this line. And Dr. Michaud and I have actually been trying to get this in place for the last several months, and making sure that we have the ability to have this in place with schedules and everything. And so we'll absolutely be moving forward with this to deliver some renal services to the Nelson and area. So please know that is our commitment, and we are looking forward to having these renal services in the area. So we will also provide some of that information you're asking for. I think it was, I just saw the name Andy. I apologize, I lost the last name. We absolutely will get some of that high-level information you're asking for.
Thank you, Chair. Thank you.
Okay, thank you, Director David. I'll have Director Chapman next.
Yeah, thank you. Through the chair, I'm not quite sure I understand the last comment about commitment, whether it's the commitment to the kidney care clinic or commitment to more. And I'm worried that our questions might become a little bit circuitous. But we have a lot of people who aren't board members on this meeting. I can see from, what shows on the board there, there's 45 people online. There's people in the room, including member of public. So just to touch on 2 points, I heard, if there was a burgeoning population, and I also heard a comment, reevaluating every 6 to 12 months. So burgeoning, no, not like Surrey, but we are growing and we're aging. And so I guess that's part of your 6 to 12 month evaluation, because you must have projections. You could say, yeah, you have 9 today, you might have 4 later, but you might have 13 or 15 later. With aging, hopefully you have projections. So all I can ask for here is sort of give community members who are listening and taking the time to sit in and appreciate your time. You're taking a great deal of time to bring this to us, to give them either some hope or to reset their expectations. Would they expect that in 6 to 12 months that they would hear something more concrete or an update? And within, say, 12 months, would IH even put out feelers? Maybe there are staff members, trained staff rather, who would move into the area, not rob some other department, who might say, it's a nice place to live, and they're professionals, and they can afford to and want to live in this kind of environment. So what hope or what expectation should the public, who can't ask any questions right now, what expectation should they have over the next 6 to 12 months?
So maybe I'll start and then maybe Donna can add in. I mean, I think the expectation would be, as I understand it, that Dr. Michaud and Donna and colleagues are working on establishing a kidney care clinic. That will do 2 things. One is to educate the populations and offer them best opportunities to both delay progression of kidney disease, as well as the things that go along with kidney disease, which is heart disease and everything else. It's a very positive time in the whole area of kidney disease right now. And then, even though you're aging, what we found, and if you look around the province, the people that do the best with home dialysis are actually older people. And so the more people, and aging doesn't necessarily equal need for a dialysis unit if your first and best therapy is home-based. But I think the real commitment is ongoing and regular evaluation and the establishment of a kidney care clinic with access to best medications and strategies to delay progression and keep people healthy. Because that's what we're really trying to do. We think that building dialysis unit means we failed you. It means that we haven't given you the opportunity to delay progression. And for the first time in the kidney world, we really do have ways to delay progression. So we're excited to be able to bring those to Nelson and to the whole province for that matter, but really important. So I think that's what we would commit to as a community of people interested in helping people with kidney diseases. But Donna, maybe I'll give you the floor now.
Thank you. And I think, when I hear the advocacy and the passion and the compassion behind the request for services in Nelson, I think I said this in the last meeting. I think it's remarkable, it's admirable, and it's important because it's really hard to articulate or share. It's just one thing. If we just focus on this one thing, then we can make it happen, because it's not just one thing. And I think I really heard in the last question, if staff move in this area in 6 months, can we hear something concrete? And then maybe perhaps we can make this work. And it's not just one piece. There's several pieces of I don't know, criteria, work, etc., factors that need to come in place. And I think in some ways, like Dr. Levin just spoke about, some of those pieces, we're hoping earlier intervention, some of those pieces actually won't come to fruition. We maybe won't need a dialysis unit sooner than later in the Nelson area because we've done earlier intervention. We've brought this kidney care clinic to the area, and we've been able to intervene earlier in what we call a renal patient journey. And so by doing those earlier interventions, people don't need dialysis, or at the other end of someone's journey, we've been able to bring in more home modality for people and support people dialyzing at home, where we're not maybe right now. So somewhere at the beginning or the end of somebody's renal journey, we've been successful, even more than we are right now. And we're growing provincially in interior health and doing some of those interventions. And so, but one thing I do want to reassure you is there's another comment or statement I heard in there about projections. Surely you know projections, and absolutely. There's provincial projections along population growth, around chronic disease. We know with renal disease, chronic kidney disease, diabetes is a factor, etc. We know those pieces of information, and we absolutely are watching those. So for our program specifically, we're taking a look at where the populations are growing within our whole health authority, not just in your region. And we're watching some of those populations as they grow or decline as people move around. We know that. We saw lots of rural areas grow in population with the pandemic. People wanted out of those big cities. And then we saw lots of pressures on some of the specialty services because the smaller communities don't have those specialty services. Like I think we're experiencing, you have to go out of that small community to access some of those. So we're absolutely watching those. I want to reassure you, it's not even just a 6-month mark. Okay, let's take a look. It's continuous. So we are very fortunate in interior health in our renal program to have our own data coordinator. She just belongs to the renal program. And that's her full-time job, is monitoring all data associated with the renal program. And so she has created a data map for us. And we track and trend all renal data. So the province has data associated with BC Renal, interior health, then it trickles it down even to more finite numbers for within our own program. And we are absolutely monitoring that. So please know that it's not just twice a year, it's constant. There are so many data reports that we are watching because it's very important to watch where the population is growing or where the need is growing. So I think a big important step for us is to absolutely get this clinic going in the Nelson area. I'll work very closely with Lennon because I know the Kootenay-Lake Hospital is obviously where it makes the most sense to find a space to have that clinic come and start to serve some of the people. Again, I know it's not dialysis, but that's where we absolutely become very acquainted with the people who may need dialysis and begin those interventions early so that maybe we can slow that progression or look at home modality options for people who may be moving on to needing dialysis or what you may heard called renal replacement therapies. I'm hoping that answers a little bit of that question and reassures you that we absolutely hear your advocacy and we are listening.
Did you have a supplemental, Director Chapman?
No, thanks.
Can I say something quickly?
Yes, go ahead.
So it's actually just back to the 9 patients that need dialysis right now. That I'm not sure if they're in the audience somewhere, but my question, and Donna, actually maybe you can help me with this because I don't remember exactly how this would be arranged or advocated for, but what about transportation for these patients to come back and forth to dialysis? Like, I think that's a big need. And I'm not sure what interior health can do or how to advocate for it because I'm the medical director, so I don't do operations. But is there something that the community can do to advocate so that there's transportation provided for these patients?
Are you asking me, Dr. Michaud?
Yeah, because wasn't there another site that has this arranged for other services? Like, I'm not sure what's available, but I'm sure the community is not sure what's available. Maybe you're not sure what's available, but
I know that the renal social worker works with each client or patient that needs to travel from the Nelson area to Trail to see what their needs are and if there are barriers to transportation. And then from there, if there is financial burden that is placed on that person because of the need to travel, then there are subsidies that are available if they meet those requirements. Those are not interior health subsidies or requirements, though, so they need to meet criteria or mandates that are set up by those specific subsidy grantors.
Or is there, like, do we advocate to find volunteer drivers for these patients? Like,
well, I think that's something, Marie, that would be interesting, right? Like, if there is huge hardship and there is some way that Nelson, I mean, it's different than dropping people off at cancer treatments because, as I think one of the members mentioned before, this is truly 3 times a week. But I know that the schedules for the people have tried to be collated so that there are groups of people going to trail and coming back. So perhaps as an interim step, for those people where travel is a hardship, perhaps there can be some volunteer driving organized, through the Nelson community, and that may be a good interim step. I think it's been difficult. BC Renal has certainly begun some conversations with the Ministry of Transportation and stuff, but as all of you know, those things take a long time. But sadly, we're in the healthcare business, we're not in the transportation business, and it becomes very difficult to put our finger into every pie. But we have, made some noises around the fact that these sorts of hardships need to be somehow mitigated. But if the community of Nelson can come up with a creative solution as an example, that's also fine. It'd certainly be, we couldn't support it, like we would support it metaphorically, but not monetarily. But I think that's a good question.
Thank you. I have 2 more speakers, but I'm going to interject. We're talking, you've been focusing on transportation from Nelson to Trail, but as Director Watson, as our first speaker, articulated, there are people who are, 3 hours away from Nelson, and then it's another hour to Trail. And that's just in her area. There are other patients who are in the same situation, so it's not as easy as it may sound. There are volunteer driver groups, and they're responsible for other people's lives during that time, and it's a huge commitment for them, both financially and time-wise, and so it's not as easy, and public transportation just isn't available from some of the areas on the timelines that are required. So I will go back to the speakers list unless you have a response to that.
No, I think you just highlighted the complexity. Like if you solve one problem, that's still another problem because there's, no matter where you put a unit, there will be people that have to travel, no matter where you put it. But thank you for highlighting that. And I think we're all very sensitive to it. It's just, again, perhaps it's something that Dr. Michaud can ask the physicians in Trail to review all of those patients and look at, how many of them could possibly be home therapy patients. And that would be something that would, reduce the number needing to travel, especially for the person that's already 3 hours outside of Nelson, which is a 4-hour trail. But no solution will fix it for that person. But thank you. I'll be quiet now.
I may be so bold. I just see that there's comments in the chat about free volunteer service. So it sounds like the community has stepped up, but I'm not trying to minimize or negate the barriers that are caused.
I have 2 more speakers. I have Director Popoff and Director Page, and then I think we will move on. Director Popoff.
Yeah, thank you, Chair. I believe all of my concerns and questions have been addressed by Interior Health, and I feel that they understand our problem that we have, and by their responses, I believe that they're doing their best to try to resolve it. So I will pass.
Thank you. Director Page?
Yeah, I'll try and sell myself here a little bit from some stuff I heard from people. So the advocacy that's been hitting us, and if you've been talking to Mayor Morrison, I know she's reflected this back at you, is that the financial burdens and the logistical burdens and the burdens on volunteers to transport people are great. They're greater than the long-term volunteers necessarily can support. So I think there needs to be a look there at how those people that are stepping up to fill those gaps can be compensated and make sure that they're get their time when they bring people over to dialysis is taken care of so we can continue to attract volunteers. We're a very helpful community, but people are stretched thin, and so it's hard to find those places to juggle. And so that can be looked at. I heard that wanting to tap into that Nelson community volunteerism, and with the kidney care clinic and the educational opportunities, does Interior Health have programming that's meant to bring those volunteers together, whether it be we've had letters of support from Rotary, whether that's coordinating event organizing with Rotary to have that training available for home administration at the Kootenay Care Clinic or in coordination with the Kootenay Care Clinic. Like I hear the desire for the community to step up, but it seems to me what organization is going to lead the organization of educating those volunteers and taking intakes and making sure that that gap is getting filled, and that the communication of home dialysis in those situations where it's appropriate is truly delivering better care. Because if that message was already getting out to the 9+ patients in the area, we would probably not be hearing as much of the need for advocating that we are hearing now. So obviously there are multiple unmet needs within that population. And I think it has to, some organization really needs to hold the bucket at the end of the day when we need to organize volunteers to fill these gaps over the long term, because it can't always just come irregularly from the community as these pop up. They are part of the healthcare delivery. When we're doing it inside of a rural context, I don't mean to be preachy, but when we're doing it in that rural context, it is a severe logistical nightmare to have to travel all the way to Ainsworth, ask someone to do that for you 3 times a week. They may be family, they're probably not family, and they're taking hours and hours and hours of the day to support those people every day. And it's an unrealistic burden to expect that to be coming from volunteerism all the time if someone else isn't organizing a program around it.
Yeah, I agree with you. I think, and this is just a little philosophical, I think volunteerism is wonderful. Our healthcare system, I'm not going to pretend that it's perfect. Everybody knows that there are parts of it that are broken. And how do we compensate volunteers without starting a whole nother infrastructure of bureaucracy, right? Like, I think that's something that is a challenge, but maybe we can be creative and think about how to do that, because I agree with you. We put a lot on communities and families because of lack of and it's not the people that are talking to you here that are broken, but the system is broken, and we're all trying our best. But it's a very good point, and let us take that back, because BC Renal also has a reputation for being trailblazers, and maybe there's some way we can think of to demonstrate a reasonable but not excessive compensation for volunteerism in situations like this that might actually be a model for the province. So thank you for that thought. I think it's something we can take back, Marie, to the medical directors and Donna to the renal administrators, and think about how we might do this, because I think there's a lot of merit in what you've just said.
Yeah, thank you for that question, or maybe we'll call it a challenge. I absolutely think it's a great idea. And Adira, yeah, I have some ideas too around how this may be a possibility. Yes, you're right. I think obviously there are some things we need to work through.
All right, did you have a supplemental clarification?
No more speakers.
All right, so I'm going to just make one final comment. This, in my simplistic view, if patients can do home dialysis, and you are confident that they would be safe doing so, some of those patients, in your view, as professionals, is there any harm in having a space, not having a full renal, so maybe it's not a chair, not a full, with the support staff that you're saying is required, but just for their peace of mind, a space for them to go that if there is something that does not go well, they're still not hours away from a hospital if they end up in a crisis situation doing a home dialysis. If they're fine doing it at home, why could they not be fine doing it having that procedure done in a space in the hospital where there's that comfort level, that there is assistance close by? That may be very naive view, but that's just what I am seeing.
Yeah, no, I think it's a good question, and we ask ourselves that too. I think it's one of those slippery slope things in terms of liabilities and risk aversion and what institutions can and can't supply, and then you don't actually fix the problem of travel. You're still getting people to travel somewhere. So I think it's an interesting idea. We have talked about it. There are places in the world, I happen to be in Australia at the moment, so there are houses where people go to dialyze that have no technicians or nurses, but they have like a call bell so that if there's something that happens. But the other thing is there's the value of other people doing dialysis to help you. That's a very different model than we have in Canada. And it gives people that, what you're talking about is that security and peace of mind. But to Dr. Michaud's point and other, like, I think that if people are living, with friends or family or close by, then hopefully with the training and the support that we have given people, that they wouldn't feel insecure. But I think the ideas that you raise are all to be thought about and explored and looked at, but I'm not sure that within a hospital setting it makes sense, because there are rules about what can and can't go on in a hospital without certain people around, sadly. But those are hospital rules.
All right. Well, I thank all of you for your time, and I thank all the directors for your patience. I know this was a long presentation, and it's normally not something that we address, but it's very important for the people in our area. So thank you again. And I understand one of you is logging in from Australia, so I don't know what time it is there.
It's morning, don't worry. It's
okay.
fine. It's morning.
Great. Well, thank you. So we'll move along with our agenda.
Thank you very much.
Thank you for allowing to participate and for the very thoughtful conversation. We really appreciate it. Thank you.
Thank you. All right, so we'll move to the Interior Health Update Report. We've got Todd and Lannon. Welcome.
So, Chair, point of order.
Did you want to go back to 5.3 where you
No.
Right. We read the agenda, so 5.3 would be the next item.
I was just moving right along. Great. So.
Yeah, Chair, I'd like to nominate Director Popov for the Arrow Lake, Slocan, Castlegar-Nakusp Executive Committee position.
Director Popov, would you accept?
Yes, I will. Thank you for my nominator.
Grace McGregor, I'd like to nominate Director Sharon Gibbs for the Boundary, please.
And Director Gibbs, do you accept?
Yes, I do. Thank you, Director McGregor.
Director Gaffney?
Yeah, Jackman would like to nominate Director Page for the Kootenay-Caslo-Nelson-Samo cluster.
Director Page, would you accept?
Sure. Yeah.
Chair Hewitt?
Yes, go ahead.
I'd like to nominate Director Martin for Greater Trail.
Director Martin, would you accept?
Yes, I do.
Are there any other nominations for any of those positions? All right. So then, and for a second time, or I guess it's, second time, and a third time. All right, so thank you. So your directors are, for the executive committee, our directors Plumhoff, Page, Gibbs, and Martin. So can I have the motion to accept them?
So moved. Point.
Director Jackman. Director Weatherhead. Anyone opposed? Motion is carried. And all right, so then now we'll move into the board meeting. We acknowledge and respect the Indigenous peoples within whose traditional lands we are meeting today. So we'll move to adopt the agenda with item 11, adjournment, be cut to become item 12, and the inclusion of item 11 in camera.
So moved.
By Director. And we heard somebody's voice online. So we have a second. And
Chair Hewitt, I have a question.
Just, there's a. Are we under control?
Yeah, we're good.
All right. Yes. Go ahead, Director Marino.
Am I able to add an update at the end?
Yes. What item number would that be?
9.6, Chair.
9.6. Okay.
Okay, thank you.
All right. Is that so for the amended agenda then? Is that saying mover and seconder? Okay. Anyone opposed? Okay, that motion is carried. And adoption of the minutes of the October 25th, 2023 meeting. So we'll just change that date to 2023 for the adoption of the minutes. Moved by Director Weatherhead, seconded by Director Jackman. Actually, okay, anyone opposed? It's carried. And now we'll move to the delegation from Interior Health. So welcome, Todd and Landon.
Thank you, Chair Hewitt. Can you hear me okay?
Yes.
Thank you. Awesome. Congratulations, Chair Hewitt, on your election tonight as chair. Looking forward to working with you. Congratulations, Acting Chair Marino, on your election as of the acting chair, and our appreciation in working with you as chair over the last year. Chair Hewitt, I do have, Lana and I do have a presentation that I will lead us through the slide deck initially. We'll pause, I think, in a couple places strategically during it for questions, especially as we go through the funding request items. And then Lannon has a few items to update the board on as well after we've gone through the PowerPoint presentation. So is it possible if we could load the PowerPoint on the screen, and we'll get started?
I think you have presenting rights. Can you load your presentation?
Okay, all right. Christine, if that's okay with you, then yeah, I will do that. Here we go.
Sorry, but we've got Angela as our support tonight.
Okay. Christine's in on her way to Columbia.
Oh. Christine's going somewhere nice and warm.
Share. Okay, am I sharing my screen, directors? Can you tell? Can you see?
Yes, we can see it in the boardroom.
All right. Okay. I'll start off. I'm sure I know you also did this, but Interior else would also like to recognize and acknowledge the traditional, ancestral, and unceded territory of the Kootenay, Chinaka, Iqaluit, Shwepum, Statlim, Silix, and Chilcotin nations, where we live, learn, collaborate, and work together. So I have a bit of an agenda. Chair, I'll start off with an update on the MOU document from last fall in terms of where we're at overall as an organization in working with our 7 regional hospital districts and our IH commitment to do better in certain areas going forward. We'll go through the funding request letter, which is in the meeting package, and then have some time for questions. So in terms of the MOU, the bulk of the document that the board saw in camera back in October, I believe, really formalized a lot of the traditions between IH and all 7 RHDs within our geography that we work with and partner with. One of the things that I'd like to talk about, though, is really what's going to be different from what we knew traditionally. And there's several items that really are going to fall on us to provide more information. Yes? Sorry, Todd, through the chair. Are you able to put on presentation mode so that you can move the slide? Because I think that you're talking to the next slide and nothing's moved on our screen. Okay, hang on. I thought I did here. I'll try sharing again. Okay. There we go. How about now? Okay.
Yes.
All right. Okay. Yeah. Stop me if I make a mistake on this one again. So, directors, in terms of what's gonna be different, it's really gonna be around IH doing some work to provide better information on for future planning for all 7 regional hospital districts. We had been doing some future planning in past, definitely pre-COVID. In the last few years, for various reasons, we stopped sharing some of that information. Some of it was just the uncertainty around COVID that really wouldn't have wasn't very meaningful, I guess, while we got through the pandemic. But now that we need to get back to a business as normal and business as proper. Some of the things that we've committed to do as part of the document is the first bullet is to provide all 7 regional hospital districts by November 1st a draft copy, a sneak peek, if you will, of our funding request letter that we always get out to the RHDs formally just before Christmas, but get a chance for you to see it early, which provides an opportunity for dialogue. It provides an opportunity for RHDs that have to set draft budgets for the following year to have some more meeting information to use for it, rather than, in essence, just I think what most RHDs do is they just use their previous year's budget as the initial preliminary. There'll be better information that you can use for that. But really, opportunity to talk about the items that are on there. Hear RHD concerns, and as well as for the health authority to provide kind of where we think we're going, which is coming into the second bullet. So in addition to a sneak peek of where we're at for our following year, also give 2 to 3 year capital information. This is something that we're looking to provide on a facility basis with some item detail and some preliminary cost information. Looking at 4 and 5 year capital forecasts, so that may be more lump sum numbers for planning versus the granularity of site and item, as well as providing 5 to 20 year vision or timeline, and that would be for those big projects. So those are commitments that we've made and that we're going to work hard to provide before that November 1st date. This first year coming up will be, our first go round at it in working on that together and looking at again planning in more granular and more long-term basis. We'll work through it. I think our information will get better as we go, but if you don't start, you never get there. Looking at the third bullet, the other thing we're looking to do or committed to do is providing more information on really what's inside projects, especially those bigger ones that cost over $5 billion. So more detail on what components and what our costs are. And in terms of the fourth bullet, providing some better reporting on our project status. So there's the project status report is in this meeting package as usual. But how can we make that more meaningful for hospital districts and their directors? And the last commitment was to again reestablish something that we did before COVID, which was where the hospital district chairs and IH senior leaders got together for a meeting, which I think provided an opportunity to talk about issues, but also kind of build a more personal relationships as well. So commitment to getting back to those. So Chair, really in terms of the MOU, this really is what is kind of different, and we're looking forward to working through this. And we may need some help, and we may trip as we move. But again, we'll start down this path, and I think we'll all be in a better spot at the end. I think before I go on to the funding request letter, Chair, is there any questions on the MOU in terms of really what IH is looking to do different?
Are there any questions from directors? Put your name in chat. If not, I do have one. You were referring to biannual reporting. So biannual, just every 2 years then, rather than semi-annual?
That would be semi-annual, Chair.
Okay. So that leads to my question. Do you have any idea which months that would be? Because that would help us for scheduling our board meetings so that we're in sync. We don't want to schedule our board meeting for the month before you're ready to give us an update. And then we're ended up waiting, a lot more months.
So I would need to confirm that, but I am it's quite likely it would be broken in based on our fiscal year. So there would be April to September as being the first half, and then October to March as being the second. But I will confirm that to your staff through to Stuart, Chair.
Thank you.
Okay.
Any other questions? All right. Thank you. So you can go on to the funding request then.
Okay. Thank you, Chair. So before I get into the details, directors, some of the key themes that are coming through both through the West Kootenay District in particular, but throughout our health authority and really provincially and nationally is cost pressures and escalation. So we're continuing to have to come back for increases to projects that we previously went to both this board and other boards for. There's 2 items that were on our letter when we get into the details where we're asking for an increase in order to meet the minimum work that we need to do. Chair, some of this is kind of cleaning up the last of our estimating that was pre-COVID. I'm hoping as we move into the future, we have fewer and fewer of these. But that is part of what what we had to deal with as part of our capital budget this year. Keeping our key infrastructure up to date, replacing items, and making sure that, especially for some of our key building systems like chillers and boilers, that we're we're ready for what we're seeing in terms of changes in the climate that are happening all around us. We're several strategic priorities for both our health authority and for the province, where we've made some investments, primary care, mental health and substance use, and safety for sure. That were things that we had to balance as we try to come up with what are the items that are of highest need, as well as continuing to invest in technology, which is kind of the key for our survival and moving forward in the future.
Hey, Todd, can I just ask you, was your slide supposed to have advanced, or we're still on the Emily?
Oh boy, what am I doing here, guys? Share entire screen. Okay. How about now?
No, we're just seeing the Hollywood squares.
I'll try sharing again.
Okay.
And
we do have
I think when I'm on slideshow, something is. All right. Can you see now?
Yes.
Okay. Okay. So in terms of our ask for this year, our total ask for the board is a little over $2 million, compared to our previous year. Last year, our ask was 7.4. There was a couple big items that were included in last year's ask. The equipment for the Nelson Health Campus was 2.8 of that 7.4 million, and then we had a substantial item specifically at KBRH for their ventilation system, a little over 1.3. So there were a couple big items that made up our ask last year. So looking through our list for this year, I'll go through the detailed list of projects. Do you see a slide that says construction projects over 100K, Chair?
No. So, Angela, do you have that presentation? Because it appears that it might be easier if you do. I won't be able to see it. Wow. Oh, okay. But I can.
Do you want to go to the agenda?
Work in the agenda package. If you open the agenda package, it's in there.
Should I keep going through slide 10, Chair?
As well.
Yes.
So starting off with projects that are over $100,000, we have the first one is upgrading the fire alarm system at the Cascar Health Center. Not quite 1.4 million in total, with a $550,000 request to the board, and that's upgrading a system that's at the end of its life. It's over 40 years old. The second item within this category is in Nelson at the hospital there. The building voltage regulation system, which really is in between the utility coming into our facility and our main distribution for power throughout the building. We'd previously requested $137,000 from the board, and the total project has gone up. So there's an increase for a revised total of $225,000 on this item. So one of those ones where we're seeing project pressures. We move into our next category, which is projects under $100,000. The first one at Boundary Hospital in Grand Forks is a washroom project to renovate and expand a washroom to make it accessible for patients, wheelchair accessible. $96,000 in total for this project, $39,000 request from the board. Similarly, at Grand Forks, an upgrade to one of our air handling units there that supports both patient care areas and some of our office space. Not quite a $100,000 project with a $40,000 request to the board. And third item in this group, in Caslow, another air handling unit that is also quite old with a $30,000 request to the board for that item. If we continue with projects under 100,000 at Arrow Lakes Hospital in the Cusp, an air handling unit there, another replacement, a $34,000 request to the board. That one a little over 50 years old. And then the last project in construction projects under 100,000 is at KBRH and Trail, replacing some boiler pumps used to circulate water through the boiler system there, a $40,000 request to the board. If we look at our digital health request this year, what we're looking to do is continue with the My Health Portal expansion, which allows for patients to book appointments and see their test results. So we're continuing to invest on that structure, in that infrastructure IH-wide, protecting our data from cyber attacks, from security, making sure that we have the capacity as we move into more cloud-based services is a key part of our digital health investment, as well as continuing with primary care transformation, which is really working to build an electronic health record that's fully accessible by all providers who need to access it. Again, I can't tell if you can see my slides anymore, but overall, our IH-wide investment in digital health is not quite $13 million, $12.7 million, where each 7 of the hospital districts share in that based on their population on the 40% share, with West Kootenay's share at a little over around 10%, which would equate to a $515,000 request to the board.
And
Moving
just
into
as a note, we can't see your presentation. It's moving.
It's moving. Okay. All right. Thank you. In the equipment category, over 100,000, the first project is another one where we're looking for an increase an increase of $80,000 from the board on the Nelson waste and cardboard compactor, where we're getting a new machine as well as having to build a new docking area with some lighting and a covering for weather. This project is going up to a total of $522,000 from $198,000 in total, with the RHD request to your board from $79,000 up to $209,000. Second item in this category at KBRH and Trail, a replacement of a steam sterilizer that's used in our operating room area, replacing a unit from 2003, so a little over 20 years old. $130,000 in total, $52,000 request to the board. And then our last item in the over 100K category for equipment, also at KBRH and Trail, is the mammography specimen imaging system. That piece of equipment, $135,000 in total, with a $54,000 request to the board, with the current unit being at the end of its life. Chair, in terms of our equipment under 100,000, the total request for the board, not quite 1.1 million in total, with an RHD share 40% at $436,000. For your March meeting, Chair, we will have that initial list of what our items are by site. We just don't have it ready for today, but we'll ensure to get that to your staff so that we can have that available for your March board meeting. It's a preliminary list. There are some items that may change over the course of the year based on unforeseen circumstances, but for the most part, it holds pretty true. But we do provide a final reconciliation report at the end of the year that details the actual spends by site and by item. Chair, there is one other item that I do need to make the board and your staff aware of that's not on this list.
It is related to the CT scanner at KBRH and Trail. That item was not included in our capital budget. The CT scanner is around 10 years old at Trail. We anticipate that we'll be able to wait until next year to replace it. But in between the time when we finalized our letter that we sent out in December and what we know today, we did have a service issue. We did have a breakdown where we're able to get a repair, and it is holding for now. But we do have a risk on this one, Chair, that our initial hope that we could wait till the 25-26 fiscal year to replace it may not hold true. We may have more information on this come March in terms of the repair work that was done. It is a substantial item. Replacing a CT scanner is around $3 million in total. If we have to do it, we anticipate, and our plan was to hold off till 25-26 for that item. We'll keep you informed on it, but it is a risk we're trying to manage currently.
Thank you. And we do have now a couple of questions. I have Director Lockwood and then Director Jackman. Go ahead, Director Lockwood.
Thank you. Thank you for the presentation. I just have a couple of questions. When we put down revised total, to me that makes it sound like that IHA has already asked for the other amount, and now you're coming back asking for a higher amount because it came in at higher. So if you had already asked, at what point was that, and had we already approved that project? That's my first question.
Yeah, so both items were approved by the board at the lower amounts in prior fiscal years. So the amount that we're looking for is just the net increase, and that is detailed on the I'm not sure if you could still see my screen, but I'll go back to this item. But your previous bylaws are noted on here as well. So it is just the increase, and that is reflected in the green column. So on the building voltage regulation system, for example, 137 is the net increase, 40% on that item, and then on the Nelson cardboard compactor, 79,200 is the net increase at 40% for that item.
Okay, I guess I'm reading it backwards because it looks like it says that it's funding requested as 137. So, okay, thank you for clarifying that I did actually just read it backwards. My other question is, if I may, Chair, the digital health with the self-booking appointments, I know how much difficulty it's been for some of the population out there to book lab appointments and how frustrating it is. I still deal with people in our community because it's so much easier to talk to a human. And then we're turning around and having to pay for cyber attacks. So can you give me where the decision came from that we're going to move to more of a digital appointment where we have the risk of cyber attacks and not use humans? Just so I can explain that to people.
So Lennon, I will maybe start off on this, and maybe if you could maybe expand at the end and correct where I may be maybe not 100% accurate. But Director, to your question, our intent is to allow self-booking, but also still continue to have the ability for patients that either would rather talk to a human, that they still have the ability to call in and book an appointment through our booking staff and through the telephone system. Lannon, can you help on that one?
Yes, through the chair, that's accurate, Todd. There is no intention to remove telephone access.
this really just gives another opportunity, and for those that are savvy with the technology, it's a preferred method rather than having to speak with somebody. There is still risk. Our booking system is electronic, so whether that booking occurs over a telephone or over the internet, there is still an interface that exists electronically, and systems are in place through our digital health team to protect our infrastructure, our technology infrastructure.
Did you have a supplemental?
I have just one more and then I'm done. When we look at project summaries and we see that the date that it started, which was some of them are before this meeting, what would happen if we didn't actually support the project? Would the project still go forward and IHA would totally fund it, or what would happen with that project? And that's my last. Thank you.
Okay. So Chair, on that question, maybe I'll start off that RHD participation on any item is it is up to you. It is voluntary, and that applies to all 7 regional hospital districts. If the board chose not to support an item, then really what we would then really look at is what our options are limited. But it really comes down to is it something that we can't do without? And then if that's the case, where do we reallocate from within our fixed amount of funding that we have? So the 60% portion that comes to us from the ministry, there isn't an avenue for us to go back to ministry and say, this RHD didn't support this item. Can you backfill the 40%? That's not how it works. We then look at our overall basket of capital and where can we shift? Where can we reallocate? Maybe we delay, and but it's it is a zero sum game for us in the end that we have to work within.
All right, and thank you for your questions, Director Lockwood. Director Jackman.
Yes, thank you. Through the chair, Rod, you did mention something earlier, like even under the MOU section about improving reports. I like your reports with the color coded stuff like that. You do have an anomaly this time, a little blip, because I think it says not on the waste and cardboard compactor, not on time, but yes on budget. Of course, it's not either. Anyway, but I like your reports. I think there's enough information there. This budget is a relatively light ask, is the way I would phrase it. And of course, there's expectations always from community, from taxpayers, that, well, are they going to get some tax relief and when? So again, I want to stress as soon as you can, whatever you can, giving us those longer term projections, what might be in the mix, is important for community to understand, because we have to, at our next meeting, weigh off what is our current reserve balance and what are our projections for contributions to reserve. And an ask like this would almost tell the public, well, we can drop your taxation, and that's never the full story. So I really do look forward to seeing the 3 to 5 year projections beyond where that makes sense. Back to the conversations we had years back when we said, well, we might need 75 million, and then people could truly understand why we started putting aside 2 million a year in reserve year after year, because we don't want to get into a difficult crunch with borrowing money, not knowing interest rates. So looking forward to seeing the additional information, and even whatever information we can give the public by the time we do get into our March meeting, so they understand what decisions we're going to have to make around taxation going up, down, or stay steady.
Thank you, Director Jackman. Yes, I'm not sure in terms of our commitment under the MOU how much we can get you between now and your March meeting, other than what I did share on the KBRHCT, which would be significant, 3 million at 40%. That absolutely Our hope is that it'll come to you in the 25-26 fiscal year and not before that. Just on that, but on that same topic, our CT in Nelson is actually a year older than the one at KBRH and Trail. Doesn't perform as many exams, so we didn't have the repair issues that we've had recently at KBRH and Trail, but I could say with a high degree of certainty it'll likely follow fairly quickly in behind the Trail item for replacement, at that same 3 million-ish order of magnitude.
Would you have a supplemental?
No, it's just good to know that the public realizes rather that they know we have to consider reserve balances, because if we're going to be a partner who can step up in short notice, we have to hold some amount of money.
Thank you, Director Jackman. Thank you, Director Watson, for that. Director Schmenk.
Thank you, Chair. The power regulation at Kootenay Lake Hospital, is that something we can expect at other hospitals, or is it being done there, or is there a reason why Nelson is getting this project occurring today, right now?
It is a specific risk, Director, that was identified at Nelson. I believe I can confirm this, but I'm quite confident in the work that we've done recently at KBRH and Trail, which included upgrades to our backup generators as part of the two large projects there, that we've addressed that issue at Trail at that time.
Thank you.
Are there any other questions before Todd moves on? All right, I don't see any more, so you can go ahead.
All right, that does, Chair, conclude the presentation on the funding request letter. I just again would like to thank the board and both also the foundations and the hospital auxiliaries within Kootenay-Boundary that we are all partners with in trying to meet the needs for equipment and capital for our patients in the area. Chair, I know Lannon has a few items that he would like to touch on, so if I could maybe pass the baton per se to Lannon at this time, and I'll stop sharing.
All right, thank you. And then we'll, after Lannon does his presentation, we'll just take a brief break. We've been meeting for a couple of hours.
Thank you, Chair, and it gives me a pleasure to be able to report to the board this evening. I would congratulate the Chair and Acting Chair in your new positions, and just echo what Todd mentioned with respect to our partners that we work with quite closely that support us in providing health services throughout the Kootenay-Boundary. I thought that as we are entering a new year, that it would be helpful to provide just a brief overview of services and activity that has occurred over the past year, to give a sense of the amount of work, and this will only be a sliver of the work that we are doing, but really speaks to the story of health services in the Kootenay-Boundary. So as a start, over the course of 2023, there were nearly 50,000 emergency department visits in the departments that have our EDs. There were 21,000 hours of services provided by home health nurses, both LPNs and registered nurses. There were over 8,300 surgeries performed in the KB. Over 30,000 ambulatory care visits, which would include IV therapy, cancer treatment, and other small procedures. And over 88,000 home support hours performed by our community health workers to those needing services at home. Over the course of the year, we were able to reduce the capacity, or I should say the census, not the capacity, but the census of patients at our acute care sites below 100%. We were successful in partially reopening beds at Boundary District Hospital through the hiring of nursing, lab, and support staff. We were able to add a safer supply program in the community of Nelson, one of the first in rural BC. We improved vaccine rates for those aged 2 to 7. And we reduced the cancellation rates for home support for our residents of the Kootenay-Boundary. We received funding to open up a permanent Tier 3 neonatal ICU at KBRH, expand the OR at KBRH, and we've expanded the opioid agonist treatment program in the Kootenay-Boundary. So it's been an extraordinarily busy and productive and what I would still characterize as a successful year for the work that we've been doing in the Kootenay-Boundary region. Remain very proud of the clinicians and support staff that provide our services and am open to any questions that members of the board may have. Thank you, Chair.
Thank you, Landon. Are there any questions? Don't see any questions or any hands. So I just want to say thank you for the, I do understand that BCHC has signed a contract with another physician, so we will have our full complement come summer, which is really great news for our community. Very much appreciated. So with no questions, well, thank you. And we will take a brief break. Oh, sorry, Director Davidoff, I didn't see your hand. Go ahead, Director Davidoff.
Through the chair, could we get Landon to email us those stats? Because those are pretty significant statistics. It'd be nice to have a copy of that.
Is that
certainly
possible? Thank you. All right, so it's 8:04, so we'll break. Is 6 minutes enough? All right, great. So we will see you in 6 minutes.
our government resources be applied in that process.
Right. Directors, we're ready to begin again. We got everybody back. So we will continue. We are on item 8, and there is no business arising. So new business, we've received several items of correspondence. Are there any? So those are just received. And then item 9.2, a UBCM minister meeting. So just a discussion as to whether we want to make that a request for a minister meeting at UBCM. Director Page.
Can I roll this back a second?
Yeah.
Based on the conversation we're having, maybe not ready for this meeting, it would be nice to capture the activities of these service organizations that have asked for support and connect it up with the idea of whether it be a volunteer program or some organization around training for home dialysis, and see if there's some way we can direct this attention in these service groups towards that volunteer effort.
I guess is that the role of this board, or is it more the role of the city being more in touch with it? Because we don't meet that often. So for us to be the body that tries to direct that work, it might slow it down.
Fair.
So I don't know whether there is a way that we can refer this.
Can we reply back to the city and let them know of those opportunities and connect with having Interior Health provide some additional information to inform that letter? That's all in there for.
Okay, if you can draft something to give to Angela, you can vote on. And in the meantime, I've got a question from Director Watson, and I'll give you time to do that. Director Watson.
Yeah, thank you. I couldn't completely hear what Director Page was saying, so hopefully I'm not off base here, but I think the notion of the things needed to be put in place so there is good healthcare. We do have good healthcare, don't get me wrong. But we're obviously hearing from a segment of the population who is not, who's experiencing a lot of issues. Solving that problem isn't something this board can take on, but we can advocate. So I think what's critical is we do maintain the direction to speak with the Minister of Health, but what we need to identify is that transportation is a critical aspect to rural areas. And when you centralize healthcare, that transportation cannot be the assumed way that things are working, because it's not. We have volunteer people driving people that need help. And so the fact that that is the system we're relying on is part of what we need to talk to the Minister of Health about. Centralized healthcare is not something we can solve, but we can certainly say the backbone pieces you experience in urban areas as your supports are not the same in rural areas. And so the Minister of Health needs to address that. So I would like to say, even if we don't prepare what that meeting might be at this time, UBCM's in September anyways, it is still important, and we need to include the transportation issues in there. It's great we have these volunteer programs. They cannot be how the healthcare system functions on a daily basis.
Thank you. So what Director Page was asking is how we can take these letters of support and advance them to Interior Health and try to get something happening in that regard. And he was working on a resolution. I jumped ahead too far with advance through the correspondence, and Director Page wanted to address those items of correspondence and get them to the right organization to address.
Supplemental, Chair Hewitt?
Yeah, go ahead, Director Watson.
As if Director Page is working on a motion, can I go ahead and move the motion to include a letter of support from the hospital board?
Yes, because we haven't got a motion on the table at this point. So there is a recommendation. Okay, that the board send a letter of support to Interior Health Authority, Minister of Health, and the Premier for Renal Hemodialysis Unit in Nelson. Moved by Director Watson. A second?
Second.
Okay, Director Jackman, seconds. Any discussion? Anyone opposed? Motion is carried. Okay.
On this. The board directs staff to work with Interior Health and send a letter to the City of Nelson with details about the proposal to develop a volunteer support program to improve renal services. And further that we suggest they contact the service organizations that have sent letters of support to find volunteers. Sorry, through the chair, who's they? City IHA or the city, because then it's back in the city's court, and I would suspect direction to staff is to develop more details of what could possibly be happening there. That needs to come from City Hall, but let's scaffold something and let the city take it from there.
So were you able to capture that, Angela, or do you want Director Page to email that if he can see it?
That's to address, sorry, through the chair.
Yes.
That's to address the correspondence of.
Yeah, all of them. Can we CC that letter to all those organizations? Yeah.
We'll give Angela a chance to get that typed up and then we'll read it out. Are we ready?
I think so. Almost.
Thanks everyone for your patience.
Long day, I'm not ready.
Send that to Angela. Okay.
So I have, through the chair, I have that the board directs staff to work with Interior Health and send a letter to the City of Nelson with details about the proposal to develop volunteer support program to improve the delivery of home renal services.
I forgot the program. And further, the city be encouraged to work with local service organizations to recruit volunteers.
City be encouraged to, sorry?
Work with local service organizations to recruit volunteers.
Would you like me to put the recommendation into the chat?
Yes, please. All right, so there is the recommendation as moved by Director Page. Do we have a second?
Second for discussion. I have a question also.
Okay, go ahead, Director Jackman.
Do we want, I thought we're trying not to do this work as a board. Do we want to direct staff to work with Interior Health and then go to Nelson, City of Nelson, or do we just want to direct staff to write the City of Nelson and ask them to take this on? Because I thought I heard that we're obliging Stuart to go to Interior Health, then go to the city. Well, how does it start? I want to check. Student affairs. There it is.
Well, I'll just flip my computer around.
It's, yeah, I see it. If it just said, the board directs staff to send a letter to the city of Nelson with details about, and then our staff isn't trying to work with Ontario Health, but the point was let Nelson, city Nelson do that.
Fair. Yeah, I could set up an amendment to shift it that way. And, yeah, totally. Just to make it less convoluted.
All right.
And with the actual. Yeah.
Okay, so that the board directs staff to send a letter to the city of Nelson, just removing the words "to work with Interior Health."
Yeah, it would be in the letter. That's a program that Interior Health has heard it. Obviously, looking to elaborate.
So that's been moved and seconded. Any discussion? Okay. Is there a hand? Okay. All right. Anyone opposed? That motion is carried. All right. And regarding UBCM meeting, do we want to just refer that to the next meeting? Can I have a motion to refer that item then to the next meeting? Director Weatherhead, Director Page, any discussion? Anyone opposed? Motion is carried. 9.3, the Interior Health capital funding request. The letter has been received. So the recommendation is that the West Kootenay-Boundary Regional Hospital District consider funding each of the items in the Interior Health Authority's 2024 funding request, and that staff be directed to prepare the necessary bylaws for board review and decision at the March 27th, 2024 board meeting.
So moved.
Moved by Director Page, seconded by Director Jackman. Any discussion? Director Watson.
Sorry, no, that was to move the motion. I'm good.
Oh, okay, thank you. I don't see any names in chat. So anyone opposed? That motion is carried. And Interior Health Capital Projects Planning Status Report Summary, that has been received. And accounts payable, the accounts payable summary for October to December 2023 has been received. Are there any questions regarding that? All right. And now we're on item 9.6. Director Marino.
Yes, thank you, Chair. I just wanted to let everybody know that just before Christmas, I received a phone call from Susan Brown, and she was traveling through our area, and she asked me to go to breakfast with her. So since I never refuse a free meal, we had breakfast and had a discussion about things that were happening in Interior Health in the trail area. The only thing she asked me about that pertains to the hospital board is, did I hear about the project we're going to talk about in camera session? And I said, yes, I had already, because we had our executive meeting. And then we talked about...
So you can't talk about in-camera items in an open session, Director Marino?
No, that's all. I just said, yes, I heard about it. That's all. That's all I'm going to say about that. And then we discussed what she asked to be confidential, some things that were happening in the trail area inside Interior Health, and asked me about my experience with what happened with Interior Health when I was there and what I saw happen in the community. And then we talked about plans for Christmas. So anyways, I just want to let you know I did have that meeting, and the only thing that pertains to this hospital board meeting is the in-camera session we're going to discuss a little later.
Thank you, Director Marino. All right. So since we're going in camera, is it can we move public time to right now? We don't have public time.
Sure it is. Yeah.
Oh, okay, it is. I've written over top of it. That's what it was. All right. So before we move into our in-camera session, there is an opportunity for members of the public to ask questions, bearing in mind that our delegation from BC Renal is no longer on the call. So the questions are to be directed towards the hospital board. So are there any questions for this board?
Okay, I'm a volunteer. My name is Jim Orser, and I'm a volunteer driver through Trafalgar Community Service. I take 3 people over the trail, 2 from Nelson, 1 from Trafalgar, and I do that 3 times a week, no matter what the weather is. But some of the things that people don't understand is you have to have special insurance on your vehicle. Your vehicle has to be inspected, all at the cost of the driver himself. The only thing that gets paid is for fuel. That's the only thing that's paid. We have to take these people over to trail and wait 4 hours while they are on the machines. Sometimes it's a lot longer. The biggest problem that we're having, that I am having, is a fellow in Trafalgar. He is had both of his legs amputated below the knee, and moving him in and out of the car has been a bit of a nightmare. And the biggest problem that we have is getting the snow cleared from the road getting in there. The last time we went over, it was just after we had that big snowfall. There was 4-wheel drive trucks stuck everywhere. We got through, and I still have no idea how we did it, but we got there. We get the trail, and we go to unload this fellow, and we had to call the renal unit to have the nurses come down. Because I don't know if any of you ever know how to push a wheelchair through snow that hasn't been cleared. And we're parking as close to the door as absolutely possible there. That is some of the problems that I don't think Interior Health understands. It's the disabilities of some of the people that are going there. I have people who have dementia. They're simply old and don't understand what is going on. And nobody seems to happen to think about what is it that we have to do to get these people a bus or something, because I don't enjoy doing this. I do this for them because I feel so sorry for them. They are forced into this. They have absolutely no choice. It's either that or they sit at home and they literally die off. It's not a good thing, but it's the only thing that they have. There's 3 of us in Nelson that do this. There will be 2 shortly. The one person is quitting because they just can't handle it anymore. And nobody pays for wear and tear on a vehicle, which would put 350 miles a week on our vehicle strictly for that, and we're volunteering that. But the wear and tear of your vehicle is huge because you have to travel through all the inclement weather and the good weather and the traffic. And the traffic between Castlegar and Nelson is unbelievable, just unbelievable. So the thing that I think that the hospital board and Interior Health should have to sit down and discuss is how to get your patients from where they live to trail without using volunteers. because the volunteers, I'm telling you, are fast wearing them. I made 3 trips in September to Kelowna, and 2 of them turned out to be rush trips. It's not good. Not a good thing.
Right. So Jim, so you're asking us to advocate for increased transportation for renal patients to the trail facility.
Definitely. Definitely,
So
yes.
that was what Director Watson was referring for our UBCM meeting. So at our next meeting, we will talk about that, and then staff will work on, preparing something to go to UBCM with, and because we do understand the challenges. Director Watson is the director for the area surrounding Castle, and we've got one of the larger distances to travel.
Exactly.
So, yeah, we do understand your plight for sure, and it's not lost on us. Thank you. All right. Are there any other questions before we recess the meeting? All right, well, thank you to all the members of the public for logging on and listening in, and please feel free to join us again for the next meeting in March. So the recommendation is that
I would move that the meeting be closed to the public.
all right, moved by Director Jackman, second by Director Weatherhead. Anyone opposed? It's carried. All right, thanks everyone. So I'll ask anybody who is a member of the public to log off, and so you'll have to